This is the Spine Bros podcast, and today we have a very special guest today, Dr. Walter Priestley. I'm Dr. William Sunstein of NSPC Brain and Spine Surgery, and this is...
And I'm Dr. Richard Obedian of Island Spine and Sports.
So we are very excited to have Dr. Walter Priestley here. Dr. Walter Priestley is an esteemed chiropractor who's been practicing for almost 40 years in the area. He has an office in Farmingdale and runs a very, very large, one of the largest chiropractic organizations on the island, if not in the state, and has many chiropractors. It's focused only on chiropractic care. And Dr. Priestley is also a very, very prominent member of the Farmingdale community. He's board of trustees in Farmingdale. And just loves living in Farmingdale and doing a lot for the community. As I follow him on all his Facebook and social media, I send a lot of patients to Dr. Priestley's practice. We're very happy with the care that his practice provides, and it's just been a great relationship. We love working with the chiropractors, and we thought today it would be great to really hear it from the source. Sure. Of Dr. Priestley. So, Dr. Priestley, thank you for being here.
We're thrilled to have you. Okay. And why don't you introduce yourself? Tell us, because a lot of patients want to know, how does one become a chiropractor? What's the training involved? And
Okay, well, similar to medical school, you have to take the same prerequisites like biology, chemistry, physics, organic chemistry in your undergrad, and then after then you apply to chiropractic school. And what the big difference is, when you get done with chiropractic school, you're good. When you get done with medical school, you still have to go on and do an internship and a residency. So most of us can be done if we go straight through by age 25 or 26.
But you still get some sort of apprenticeship after
we do with the last year while we're in school. We do an internship in the clinic, in the chiropractic clinic.
But afterward, you're pretty much good to go. You can start.
We're good to go.
And chiropractic is just the history of chiropractic here. It's been around since the 1800s.
1895. This guy named D.D. Palmer says he discovered it and came up with this system to relieve pressure off of nerves, and he developed it, and here we are today with probably 50,000 chiropractors in the United States and probably another 50,000 worldwide.
How many neurosurgeons are there in the United States?
I don't think
there's 50,000.
No, I think there's about 5,000. It's a pretty small club. I think that's pretty much what it is. 5,000 in the country, as far as I know from the last statistic I heard.
Yeah, I don't know how many orthopedic surgeons there are, but how many chiropractic schools are there? Is it hard to get into?
There's about I believe there's about 12 in the country.
Only 12 chiropractic schools in the whole country?
Yes.
We have one right here and locally in Levittown.
That's shocking.
Well, we only have the clinic in Levittown. We have the schools upstate New York.
Upstate in Seneca.
Yes.
Seneca. But I think things have changed, though. Aren't they coming down a little bit
they're
more?
having remote classes down here. You still get to do your clinical work down here face-to-face, but you're going to be sitting in a classroom, which my son might be going to one day, where the class will be going on upstate, and then you can interact through video teleconferencing, and you'll have the entire class next to you.
Oh, your son's going to become a chiropractor?
That's what he says.
How old is he?
He's 26. He's in the Army right now, and he's finished with college, and he's got a lot of opportunities, but he applied to chiropractic school and just got in.
What's he doing in the Army?
He's a infantry soldier. He's a sergeant, and he's a gunner on a Bradley. And he likes the combat stuff.
Where is he now?
He just got back from Poland and Germany. He's in Fort Stewart and
good for him
in Germany. I mean, he's in Fort Stewart in outside of Savannah, Georgia.
Now, does the military ever have like chiropractors that are in the military?
Yes,
that are on staff.
They do.
To help.
They are chiropractors that are commissioned officers in the military.
And will they pay for chiropractic school?
Yes, they will.
Oh, so maybe he wants to do that, because I would imagine it's pretty expensive.
That's
school.
The plan, it's expensive, but Dad's been putting away money for a while.
Medical school now, $130,000.
I don't even know anymore. I'm
afraid.
Let's
get NYU.
My son's pre-med. I'm concerned what it's going to be, but I'm just waiting.
There are limitations to how much they're going to pay. They pay for about 3/4 of it.
All right, so basically, a lot of people I know end up being chiropractors. They've had some other things going on before even, and some of the chiropractors actually
Become doctors.
or they become monitoring neurophysiologists.
Neurophysiologists, sure. We have a few of those in your practice.
But so we do just spine surgery.
Correct.
He does other things too, but mostly spine surgery. And we,
And by the way, that's my focus too. Is
and that's
spine.
and spine.
We have other chiropractors in the office, and if someone comes in with a shoulder or a knee or an ankle, I usually refer them to the other chiropractors who do more extremities in my office.
So we see mostly cervical and lumbar disease, mostly degenerative disease, and as you said, you learn how to take the pressure off the nerves, and that's what we're always interested in. And
Right.
we obviously send patients for conservative treatment to try to take the pressure off the nerves without operating on them directly. So I'm always interested to know some of the techniques you guys use in order to do that, some of the conditions, like how would you approach that kind of stuff. Certainly patients with lumbar stenosis, people with compression of the nerves, the thecal sac. Talk a little bit about some of the
I brought a
stuff you guys
prop, if
do.
that's okay. All right. Well, of course, as the doctors know, that many of these ridiculous symptoms where you get pain that radiates down to the leg or into the
Ridiculous, not ridiculous.
well, for some patients, they think it's ridiculous that they have it, but the ridiculous symptoms are originating in the spine, and this is a model of the lower spine. And this little cartilage in here, unfortunately, when it gets weak, can bulge out into that canal. Now, the surgical answer is to get in there and remove it. And it's not so easy to get in there, but it's successful for the patients that don't get better with other procedures. Well, one procedure that we would do is have the patient lying face down and identify as best we can the level where the disc material is in there and put a hand contact above there, and flex the spine like this to open up that and to draw it back away, okay? And that's called flexion distraction technique. And for a lot of patients, it's very successful.
When you do that technique, how long is usually that treatment, and how many repetitions of that motion do you do to try to get that nerve?
Okay, well, with flexion distraction technique, we spend about just only 2.5 minutes on that when we're doing it hands-on. But it would take a series of visits. I usually tell patients, give it at least 12 visits to see if you're getting some results. If you're not getting any results, then we have to try some other things. And one of the other things that's a little bit more advanced is spinal decompression therapy, where we use a machine where the patient lies on their back, and we would put a harness under their ribs, another harness on their pelvis, and it would pull the spine apart like this. Each cycle is about 30 to 45 seconds. Depending on the angle we put it, we can target a specific level. All right, and the entire procedure is about 30 minutes long.
Do patients generally say to you while you're doing that, that is definitely the thing, you got it, in other words,
right.
you
well,
got
that's
that,
why
my pain is better.
A lot of
as you're doing
times, we tell patients, try it the first time and see how it goes, because it makes sense to them. And when they're on the table, they come off and say, that really felt right to me, and they want to continue with it. Now, it doesn't always happen that way, that they feel better the first time, but sometimes they do. And even if they don't feel better the first time, they kind of understand it. It makes sense to them. And it's a lot less invasive than just about any other procedure. A lot less invasive than taking pills, a lot less invasive than getting injections or going for surgery. And all that stuff is useful, but let's start with a stepladder approach and start with the most non-invasive things first. Because as you guys know, people get spinal problems every day. 80% of the population is going to need some professional care for a spinal problem. Most of them are not going to need surgery. Even most patients with herniated discs do not need surgery. Most of them are going to get better one way or the other. So before we take anything that could put the patient at risk, unless it's an emergency situation, let's try the conservative approach with chiropractic care, stretching, exercise, lifestyle changes, and things like that.
Would there be any patient, I'm sorry, but would there be any patient where you would say, I really don't feel like we're going to be able to help you, or you have, is there any degree of spinal stenosis, for instance, if a person walks with no canal left, where you say, I really don't think we should be approaching it this way, or something like that?
Well, that's a tough question, because it's hard to know for sure. If a patient is in an emergency situation where, we have signs of serious serious nerve root compression, loss of bowel or bladder control, drop foot, things like that, we at least tell them, let's consult with a neurosurgeon, but we can try start off at a gentle level, because when we use the machine and we do the flexion distraction, we're in control. We can start it very gently and then work our way up from there. So for the most part, there's not too many patients that we would turn away unless they've had, find out that they have metastasis in the bone, or they have, or fracture or something like that. As long as it's just disc displacement, you don't know who's going to respond. And some of the cases that you think are not going to respond, and some of the cases you think are going to be a piece of cake don't respond. So, and as you guys know too, it's a complicated process, and it's not an exact science. But as long as you're starting off with something that's generally safe, it's okay to do it. And it's an investment in our time too. I mean, we only want to do it if we feel that we're going to help the patient, but we can't say no to a patient that could have got better with the chiropractic care.
So you generally will get imaging studies, such as an MRI, before you manipulate them?
It depends on the scenario, because I take x-rays in my own office, and if there's no reason to believe that they have a major problem that would be contraindicated to what we do, we don't necessarily need the MRI early on.
Sometimes they don't even give you approval of MRI unless you've tried
6 weeks. I know,
management,
it takes 6 weeks. But a lot of patients that have more serious conditions, they've already been to 2 or 3 providers, whether they be pain management doctors, neurologists, neurosurgeons, orthopedic doctors. They're walking in with MRIs, and we look them up on their portal, and that helps us direct our care.
I mean, my feeling is that if somebody has a red flag, especially if they have bowel bladder issues, or they have a foot drop, or some kind of weak neurological symptoms, that necessitates an imaging study and probably referral to a spine specialist pretty quickly, because that can get bad pretty fast, and I'm not sure any kind of non-operative therapy is going to really.
Yeah, I mean, those are very,
those are the rare
unusual situations.
Those are the rarities.
But they come up, and you have to sort of judge each
You got to know
one.
when to refer.
What is the difference?
But can I just throw something
Sure.
in? You said that the insurance companies make you wait. They only make you wait on these standard cases. If you say there's a drop foot, if you say there's
obviously we have to send to the emergency room in these situations. And that'll immediately get imaging.
But we're careful. We have never had a serious case where the patient had a complication.
Because every year you hear in the press about some chiropractor somewhere.
Yeah,
usually it's in the South.
Why don't you?
Can I comment on that?
Dispel some myths about the chiropractor?
Manipulating somebody's neck, and they end up having
that's the thing. It's like some patients come in, they're like,
They're a little fear.
I tell them, modern chiropractor in Long Island is not what you think.
So it's not something that happens very often. Why are they talking about a case that happened in Canada or a case that happened in the South? They want sensationalism. You got to look far to find these cases.
But they happened. Right?
They happen, but they happen in all sorts of areas of healthcare, and it may or may not be related to what the chiropractor did.
Hey, look, there's some surgeons out there that have had some disasters as well.
Statistically, we enjoy very low malpractice rates. So, for example, my malpractice rate is $200 a month, and I don't think you guys are paying $200. Wow. And if I get a new practitioner,
I wish mine was $200 a month.
That's not even a car payment.
I know. So and sometimes the patients that are nervous, I tell, look, my car insurance is higher than my malpractice insurance. So if I take you for a ride down to 7-Eleven and back, you're at more of a risk of getting hurt than me working on you on a table.
That is the truth, I think.
And the new practitioners, it's only like $500 for a year because they assume they're not going to see as many patients.
Wow.
And we've never had a claim, and fortunately we've never had a serious complication.
Pretty impressive.
That's very impressive.
I can show you my bills. We've had 27,000 patients come through our clinic, and the average patient comes for about 20 visits, and we've never had a serious complication or a lawsuit.
What do you do? What do you think differentiates what you do, let's say, for a primary conservative treatment of a patient with back pain, leg pain, some degenerative disease, spinal stenosis, from a physical therapist versus a chiropractor? Like, why would somebody send a person to a chiropractor first before a physical therapy?
Or should you do both at the same time, or what's your feeling?
Yeah, like how does one work that sort of thing?
Spinal manipulation, whether it be flexion distraction technique or spinal decompression, is a very powerful procedure. And
I don't think physical therapists do that.
They
No,
do not do that.
almost like you would think
They do
that
not
people
do
should
that.
know that you guys go right to the problem. You know what I mean? Right to the nerve root compression.
Right. Rather than working with the PTs are working with a lot of muscle re-education, reducing inflammation, and some chiropractors do PT in their office. We don't. We just feel that the PTs are better at that. We'll go as far as doing rehabilitative exercises in the office, but we don't get into ultrasound or electric stim. The PTs are better at that. Let them do that.
Modalities.
Yeah, we
You really
rather
go
have
hands on in your
Yeah, we're hands on, and that's what we're trained, and that's what we're best at doing, and that's why that is what our office is about. And I think that's what people want too. When they come in, they sometimes, I went to the other chiropractor and he put me on the electric stim and the heat, and I laid there for a while and they didn't do too much hands on, and then they come to me, that's what I was looking for.
Yes.
And how is it different? Yeah, it's the hands on stuff. And the other thing that's different is a patient comes in and sees you guys for a couple visits. We'd like to bring the patient to a point where they're going to practice a healthier lifestyle. And we try to educate them about the things that they're doing that might have got them there, possibly improving their body mass index, possibly changing their posture, possibly having a more positive attitude, possibly exercising on a more regular basis. But, if knowledge was everything, we'd all be smart, rich, and skinny. But it's more than just knowledge. You have to inspire people. You have to you have to get them to actually take action. And sometimes I tell patients, look, if you're not going to take care of yourself, for yourself, do it for your family so they don't have to wait on you as you age or if you're disabled. Whatever it takes. I give a lot of my patients books on inspiring books on health and wellness and running. And, as you know, I'm an avid runner and triathlete. And part of that is to create an example for my patients to practice.
When I went to visit Dr. Priestley, he gave me this beautiful sack of trail mix packets, actually, that were very healthy and very good.
Does that account for your weight loss?
I think that it got me started on the right path, actually.
Good. That's good.
No, but I mean,
Priestley,
but
kudos to you.
But that when I went to visit Dr. Priestley in his office, I mean, that was
a more powerful motivator than me making negative comments.
Well, I mean that's also true, but certainly I think that when you go to Dr. Priestley's office, you see the emphasis on health and wellness and trying to establish good body biomechanics.
Yeah, those are all very important. Sure. There's a in Long Island, there's a lot of DOs. Doctors of osteopathic medicine, and they do. Some of them are doing manipulation as well. Is that similar to chiropractic care, or is that?
It's very similar. In fact, I know some DOs that do some fabulous manipulation, and we can learn from one another. But I don't see too many doing it. Look, manipulation is hard work. You're lifting and twisting and doing all day long. And most patients, when they're going to a DO, they're not looking for a manipulation or an adjustment. They're looking for a prescription or a consultation.
I would say most DOs are not doing manipulation.
No, very few of them are. And the ones that are, I don't think they're doing them like we're doing them because we're doing it all day long, every day for an entire career. So, if a DO has someone with an acute torticollis walks in like this and you get one of those every couple of weeks and then, the DO does it, he may do a good job, but the person that does it every day all the time will probably do a better job, like the chiropractors.
Speaking of torticollis in the neck, we obviously see lots of cervical disease as well. I always am curious, like when a patient has an MRI, for instance, that has some disc herniations that are causing some compression of the spinal cord. Mm-hmm. If I examine these patients and I see that they have some very mild early signs of cervical myelopathy, how would you approach some of these patients? Because you're always worried about, obviously making their condition worse. By patients have this myth about chiropractors that they crack their necks. Please dispel this myth, and what you actually would do for something like that.
Well, just as we would do for the lumbar spine, we can do spinal decompression on the cervical spine on the table that I discussed. You can also do it manually, and for patients that have myelopathy, you'd like them to get a consult from a neurosurgeon or an orthopedic surgeon. But most patients are going to come in without myelopathy. They might have some radiculitis, and we treat them and they get better. We do some gentle manipulation. You might hear some noise come out of their neck, but
if I send you a patient with that, if I send you a patient with cervical compression,
right.
I'm not talking about like no spinal cord left. I mean, I'm talking about like some mild compression, some very mild symptoms where we agree we're not going to do surgery at this point.
Right.
And I want to send patients for conservative management. I send them to you as a chiropractor. How would you treat them a little differently in terms of that, knowing that they have that underlying issue?
First, anybody that walks in the door, we have to take, just like any other practice, we have to size up the patient, have them fill out all the proper documents so that we can read about their history, track down the medical records on the patient, find out what they've done, how significant the symptoms are, and go through the usual onset, what aggravates it, what makes it better, do the physical examination. And most of the time, if they're coming from you, they already have an MRI. I can look at that. And then before we even start treating them, tell them all the home care they could be doing. Explain to them how the cold can reduce the inflammation. If you reduce the inflammation, you'll have more room for that nerve to come out. Tell them that you can't sleep on your stomach. All right? Don't sleep with too many pillows. Give yourself a break during the course of the day. Lie down if you can to just take the pressure off your head. Maybe there are these devices you can lie on your back with that creates a little curve in your neck, and rest on that for 5 minutes every day. And go through all the home care. Most of those patients, we can give a gentle adjustment and just very gently, just the force of gravity. You might hear a little click, you might not, and then see how they respond. We've never had a case where it's caused like a major aggravation of it. And some patients will be sore, but it's almost always transient.
Well, that's why I always want to. I like to dispel some of these mindsets that people have, because I think that there's a lot of things you can offer them that they're not getting because they're hesitant.
Well, you're probably seeing a little different population because the patients are going to you because they don't want to go to a chiropractor, so they're going to a neurosurgeon.
But I try to convince them to go. I do make
the patients that are coming to me don't want to go to a neurosurgeon, so I see the opposite. And I do want to comment on that. There's a lot of people that will walk in and say, anything but surgery. I knew Uncle Joe went for back surgery, this, that, and the other thing. You only hear about the people that had a bad outcome or a questionable outcome. I can tell you, it's like a theme in my office. Patients come in on a regular basis, and they've had problems on and off during the course of their lifetime. They've tried chiropractic, they've tried spinal decompression, acupuncture, PT, injections, spinal stimulators, the whole bit. Thank God I finally went for surgery. It was the best thing I ever did. And that's the common theme that I hear from the patients that are post-surgical, the patients that went. It's almost always it was the best. And I see it in my patients that aren't getting better. We're trying to do everything. I see their life is upside down. I see it's affecting their families, their marriage. And they eventually go and they get their life back. And that makes me feel good about. And sometimes I have to give them a little push. But the fact is, the only person that can decide whether the patient needs surgery is the patient and the surgeon. Not, I can't tell them what to do. I just say, look, get a consultation, see what they have to say, because you can't keep living like this. And you guys save a lot of lives. I mean, not from dropping dead, but from getting a normal life back. But the public only hears the people that get better. They're like, okay, I'm good. And they move on with their life and they forget about it and everything's normal. They go back to work. They coach their kids' team. They retire. They live happily ever after. I ask patients, when they're 60 years old, they come in for a new condition. I had surgery in 1975 for my back and everything worked out great. I've been good since then, but now I got this neck thing on my back thing. But so the public has, just like they're afraid of chiropractic, the public is afraid of surgery. Certain patients are afraid of surgery because you have a lot of vocal minority that talks about it in that fashion. But what I see in the real world is so many people have had it and done really well.
Well, you have a wealth of experience, and you've seen patients. Like you said, 90% of patients who have herniated discs don't need an operation.
course.
You know,
90% of people that go for an MRI after the age of 50 have a herniated disc,
Right.
even if they don't have symptoms.
That's right. You find all kinds of things if you MRI patients.
With each decade, you know, you're in your 50s, it's 50%, 60s, 60%. It just keeps on going. It's part of normal aging. But then there are those cases where, you know, in your judgment, you're really not, you know, they're not getting better despite all efforts. They're getting increasing numbness and weakness. They're getting neurological symptoms. Those are the ones you gotta send them. Those are the ones who have good outcomes. Because, you know, and if you wait too long, the problem is sometimes that can, the neurological effects can become permanent, irreversible, and same with the pain. Sometimes, you know, if you wait too long, they get this
loop.
Pain syndrome.
They get a memory loop basically that's established,
and the nerve is damaged.
I know.
Yeah. Back pain is so much.
Those are the patients who end up with the spinal cord stimulators.
I find that it's very challenging when patients with spinal stenosis who come in mainly just with back pain and they don't have the neurogenic claudication, the pain down the legs associated with it. So those patients, I always question whether should we operate on them or not operate on them. You know, that's
I had a patient yesterday who I talked to a lot about this. She had severe stenosis.
But they do get better sometimes.
With a 4 or 5 spondy, has had multiple epidural steroid injections, physical therapy, chiropractic care, everything, not getting better. Mainly back pain, you know. And she described it as like, you know, when I'm sitting, I'm fine. But when I get up and walk, I can only go a certain amount and my back starts to hurt. And she's, 80 years old. And I think what ends up happening is that they limit themselves. That if they were to walk a little, if they were a little younger, maybe they had a little more endurance, then they would start getting the pain that shoots down their legs.
That's a very good point.
I think, if their symptoms are, more neurogenic claudication type symptoms, in that it's worse with walking, it feels better when they're leaning forward, like pushing a shopping cart. The back pain alone, back pain can be. Stenosis can cause back pain.
What do you think are the pain generators in a person with spinal stenosis? That's the thing that always, intrigues me. People with back pain, come in. Like, what are the generators? Is it the squeezing of the nerves themselves in the sac, or is it the facet joints? It's the disc.
A combination.
It's hard to really know, or is it just the tissues?
And there may even be some chemical irritation because we see a lot of legitimate patients with a lot of pain, and they don't have any. Their canals look pretty good. And maybe there's a chemical irritant that's happening in the lower back.
Then they don't have stenosis if they have a normal MRI, but
the patient with the pain like right above their waistline, that's very common. People have I have pain in one spot. Like, what do you do with those
muscular,
patients? How do you treat them?
Well, sometimes it could be the sacroiliac joints. We restore the mobility in those, and if the facet joints aren't moving properly, if the joints aren't going through their proper range of motion, it's going to cause a monkey wrench in the way the biomechanics of the lower lumbar spine operate. So by doing this manipulation, it frees up some of those fixated joints. Once those joints can move freely, they stop straining the musculature, and the inflammation goes down in some of these patients. So manipulation of the lumbar spine.
Yeah.
Not necessarily to always reduce the disc displacement, but to get the joints moving through their full range of motion. A lot of times we see disc herniations and the pain is on the right side, but the imaging shows that the disc herniation is on the left side. So even though we see it, it's not always the cause. It's often other things. I know a lot of people talk about this piriformis thing, but I think that's overplayed. I think it only goes through like 5 or 10% of the population has the sciatic nerve going through the piriformis muscle. I don't think that plays that big of a role in some of these low back conditions.
It's interesting because I actually think I have it actually. I sit there and I wonder if I was manipulated, would that improve things or not?
Do a case study.
Yeah, I'd like to do my own case study.
What are you doing later this afternoon, Dr. Priestley, Dr. Schonstein?
Yeah, I want to get manipulated.
Well, office hours start at 3 o'clock.
3 o'clock.
So,
all right.
You guys have late hours. That's the one thing about chiropractors. I always notice that whenever we have like a nice dinner where we have the chiropractors come for a talk, it has to be after 7 o'clock at night.
Because they're treating patients who are working, so they come in. They have patients. They got to be available when the patients are available.
We have ambulatory patients, and Saturday mornings are busiest.
You work every Saturday morning or most Saturday mornings. That's really good.
It's a big day.
And you treat all ages, correct? Like It's not just adults. You also treat
You do children.
Yes.
What's that like?
We see a lot of the school age kids are a lot of athletes, and one thing that we have to be careful to look for all the time is these kids that are running a lot and they come in with back pain, and you take an X-ray and nothing seems amiss, and but if you ask them the right questions, a lot of times you start thinking of a stress fracture, because their bones, when they're growing in that adolescent stage, the bones elongate, and the calcification, the bones really haven't calcified and become very dense, and you get these stress fractures, and you're not going to see it on the X-ray. So any adolescent athlete, I always, and they're getting pain, especially after running, I make sure I get the MRI, because if it's a stress fracture, they need to rest. They don't need the manipulation, but they don't need to be running, because it's not going to get better. And the stress fracture not only happens in the spine, I've seen them in the leg too. Kids running in track or lacrosse or soccer, and they're getting pain down the leg. You might think, sciatica, but no, you got to check for these stress fractures, and they're very, very common in the young kids. The other thing that I see that's problematic is that I don't know the whole science behind the disc, but the kids are lifting heavy compressive weights like deadlifts and squats and military press, and it's generally compressing the spine. And I don't know how many pediatric patients that you see, but I see 14-year-olds with black discs and disc herniations, and they're from, I believe it's usually football kids that are, or other kids that are lifting heavy weights too young. I think.
We see more in boys who are playing football, female gymnasts. And you worry about spondylolysis, spondylolisthesis. Those kids are more prone to those.
And the girls, we see a lot of dancers and gymnasts. Yeah. The chronic pounding.
Hyperextension activities can exacerbate it too.
And the other thing that's interesting that I see in adolescence is the parent will bring the child in, and the child will say, "Yeah, my upper back hurts." And I said, "Well, does your low back hurt?" "Yeah, that hurts me sometimes too." I said, "All right, does your neck hurt?" "Sometimes my neck hurts too." And then, "Do you get headaches?" "Sometimes I get headaches too." And these are regular kids. It's not a psychosomatic thing. Before I even examine them, in my brain, I'm thinking scoliosis, because scoliosis runs the whole length of the spine.
Yeah.
And then
usually it's not painful.
The people that have scoliosis have a higher rate of pain than a normal spine. We'll say that. It's not always not painful, but it's more painful. I know the study came out a number of years ago saying that scoliosis doesn't cause pain. I'm telling you it causes pain, because I think the study's wrong. Because we see these kids come in with these complaints, and before I even look at them, sounds like scoliosis. We do the X-ray, and they got
lo and behold,
head
scoliosis,
tilt, high hip, and a curvature.
Yeah, I always worry about painful scoliosis. They might have a tumor or an osteoma, something that's causing them to get a curvature like that, because it's unusual to have a painful skull. Usually it's not painful.
Well, I don't know.
It's more of a cosmetic deformity.
I see it a lot. I see a lot of painful scoliosis.
Yeah, we were seeing a lot of kids before who were having back pain from carrying backpacks, and we were giving.
Well, this is the thing.
My daughter's
that's not so common anymore. Because now they isn't everything digitized now? They get the books.
No, they have binders now. These crazy binders. It's not even the textbooks. It's these heavy binders.
You got to come to Long Island. You got to leave the public school system of New York City.
They have a public school system in Long Island. Why are they any better?
Because they'll get like little.
I try to get her to have that wheeled
computers, like these little computers, these iPads. Well, and all the books are on the iPads these days.
Going back to the scoliosis, if the spine isn't stressed, it may not be symptomatic. But once you start sitting for too long in class, studying on a bed, playing sports, carrying a backpack, the kids that have scoliosis are probably going to have more symptoms than the kids that don't have scoliosis.
Definitely the adults, because as they get older, they get more degeneration, and then they end up complaining about.
Well, don't you think the biomechanics is disturbed in these scoliotic kids?
Oh, 100%. And it depends on the degree of the scoliosis too.
Right. So that would cause muscle strain, maybe some occipital neuritis.
It could, but it's not such. Usually it's not such severe pain. It's really more of a.
No, it's discomfort.
Yeah.
But those kids do really well with us, because first of all, you don't want to start giving them all kinds of drugs. Their bodies aren't prepared to handle these over-the-counter things. And they're already taking over-the-counter things. And they're getting headaches. You want them to enjoy their adolescence. You want them to be social and do all the things that other kids do. But some of them don't feel good, and they're not in a good mood. And then when we start moving those joints, the restrictions go away. They're able to move their head easier. Their headaches are less often, and they feel better. And
Great. Well, next time I have one, occasionally I get a 16-year-old or somebody in that range, 16 to 18-year-old will occasionally pop in my office. The orthopedic surgeons generally treat pediatrics, adolescents, as well as adults, but we're pretty much adults in our practice. But sometimes they come in with back pain and they have a herniated disc. So what do you do with a 16-year-old? You're going to operate on a 16-year-old with a herniated disc. Of course you want to try to treat it conservatively. So those patients, I think are good candidates to go see somebody like you.
Do you think that when you do a decompression, like on the table, do you think the disc is actually getting sucked back into the disc space, or do you think it's just alleviating the pressure on that nerve temporarily and giving them time to recover? That's always a question I have. Patients ask that, do you think they're sucking my disc? And I'm like, I don't know.
It suck back in it?
It doesn't. I don't think that it does.
But I think it's
why wouldn't it? If you pull it apart at two edges, all right, one of the things that we know happens is that it increases circulation of oxygen and nutrients in and out of the discs. So therefore the disc cells have more of an opportunity to heal and be stronger, all right? Most of the degeneration of the disc is caused by lack of motion between the bone and the disc, and without the oxygen and nutrients, it becomes a black disc, a degenerated disc. So number one, we're increasing the circulation. Number two, if you create a suction over here, why wouldn't it pull it back into its normal confines? And we'll have to get you some pre and post MRIs that show this improved. And so in the process of getting more oxygen and nutrients in there, the cellular health of the disc is going to improve.
Because once it's extruded, I don't, having seen them in the operating
room. We're talking about really an extrude. We're talking about like a bulging disc that's causing some pressure on the sac. And even if you temporarily distract the patient and the disc does move,
retract.
All you need is sometimes a few millimeters or a millimeter.
You need a millimeter.
Just to get that nerve freed for that time period over a series of manipulations like that. You would think the nerve can have a chance to heal.
Do they need a daily manipulation?
No. But getting back to him, people get better without anything. So if we're just helping the body's natural ability to recover, not everybody that had a herniated disc and needed surgery live with it for the rest of their life. A lot of people, the body knows how to adapt, and just by getting a little bit of a millimeter off, that could be enough. Because I've had patients I had this one lady came in, she was like in her early 30s, 2 young kids, and she had this giant disc herniation. I should have brought it along because it was a great story. She came in and she goes, everybody tells me I got to have surgery, but I'm petrified. And I took a look at her MRI. I said, you're probably going to need surgery, but, it doesn't hurt to try for a couple of weeks, maybe a month, and see if you get better. Well, lo and behold, she started feeling a lot better. So time goes by. She had minimal symptoms, and she would just come in like once a month for a little bit of maintenance here and there. A year later, she says, Doc, I want to go to Florida and ride Space Mountain with my kids. You think it's all right? I said, that disc herniation looked pretty bad. Why don't we do a new MRI and see what it looks like?
Gone.
No, exactly the same. It's exactly the same, but she didn't have any symptoms. So the body accommodated to it.
Interesting.
That goes into what's the pain generator,
That's the whole thing.
Is it mechanical compression? Is it irritation?
As you said, it's probably a degree of biochemical irritation.
Or just a tiny little change in the way the body adapts to it.
Maybe about a wider canal and just had a little more room for.
I like the fact that exactly. I like the fact that you feel like you want to get back the facet motion, restore the normal biomechanics, because I think that's really what is being compromised in people when they have the pathology like that, and you can try to get it back to a certain point and maybe get some pain, relief from taking the pressure off the nerve. I think that's what helps the inflammatory response as well. And over time, you see the results. You see the patient gets better. Mm-hmm. We've observed a number of times actually where discs, herniations actually get reabsorbed by the body, and it depends on the state of hydration of the disc. Well, that's always fascinating. Like we have a patient coming in, you're like, you have to have surgery. How can you have? Look at the size of your disc, and you're like, yeah, no way, doc. And they come back a year later or 2 years later, and they get an MRI, and it's totally different. It's really interesting.
I've seen that, but because I have a long longevity of patients, I have patients that 10 years ago, I get their MRI. It looks terrible on my chart. And then 10 years later, she comes in with a new complaint. Did you get surgery? She goes, no. And I said, well, that disc herniation you had 10 years ago is not there. You have a different one now, but it's just gone.
The body absorbs itself.
It takes care of itself, the body.
Well, when the disc cells are out of the confines of between the bone, it's not getting the oxygen and nutrients, and it sloughs down. I explain to patients that think of a leaf and how voluminous it is. It's large when it's green. Now, when it's brown in November, it's like dust. It shrinks down. So if this disc material is out of the normal confines of the bone, it's not getting oxygen and nutrients. Over time, the cells should die down, and the volume of the disc material outside the bone will probably be a lot less. But who wants to wait 5 or 10 years for that to happen?
Well, that's the thing. I mean, you could wait till the end of
and it may never happen.
This cycle when the bones, they auto-fuse, but does a person have to endure that?
Right. And plus, they build a pattern of pain that just never goes away, and a lifestyle of pain.
What is the longest you've had a patient coming to your practice? What's the... how long have have a patient coming to you for 30 years, 20 years?
Sure. I mean, what's interesting is I have a lot of the patients who started with me as teenagers, and now they're retired, So, this one guy, he was in high school when he came to me, and he's a police officer, so now he's in his 40s, he's retired. I've seen him go through his whole life cycle.
That's great.
But I do have people from the 80s that still come in. That's the beauty of the practice, because you get to know these families for generations. I'm treating a woman now who's pregnant, and I treated her mother when the mother was pregnant with the woman. So it's just this cycle that goes on. And
has anything changed in chiropractic in the last 40 years?
Well, of course, in the 80s, we used to be able to write a claim on a napkin and send it into the insurance company and get paid. Now we have
getting harder to
go through, and unfortunately, many of the fee schedules that we participate in haven't changed. I won't name anyone in particular, but I signed on with this one major carrier in 1998, and it's the same exact fee schedule in 2025.
No, that makes sense.
So
cost of living is up dramatically.
Yeah, everything else is going up, but not that.
And
it's gone down.
That's going down, like Medicare payments for us.
Yeah,
that's the same thing.
So I can't say that much has changed, because what we do isn't really technology dependent, except for maybe the DRX. From the time I was in school to the present, they all stress proper evaluation, imaging, make sure if the patient needs to get checked out for something else, you do. But it's,
Have you ever discovered some really unusual stuff upon treating a patient? You must have at some point had a patient with an underlying tumor or some major pathological
every
condition.
patient, if they're not getting better, within a month I get them. I start telling them they're going to get an MRI.
You guys actually, I remember a chiropractor had sent a patient with a brain meningioma they picked up because the patient had weakness on one side, and it wasn't the spine, it was the brain. They discovered it. But, you guys see all kinds of things, Well,
I had an interesting case, and it's only because there's something to be said for people having a particular doctor that they go to, because there's certain judgment calls that have to be made. So this woman in her late 60s came in to me, and I had been treating her for several years. And as soon as she walked through the door, she wasn't the same woman. And she told me, look, Doc, I'm having this numbness and pain in my arm. I think I got a pinched nerve. And I looked at her face, and I didn't do any testing or anything. I said, no, we got to go to the hospital. I just drove her right over to St. Joe's, told them, I think she's having a stroke. Work her up. If she doesn't, send her back. Otherwise, and then a couple of weeks later, she sent me a nice gift saying I saved her and that I was her guardian angel.
You drove your patient over there. That's the kind of care you get when you go to Priestley Chiropractic.
You do. You do whatever it takes.
How many chiropractors do you have currently working in your organization?
There's 5 of us, soon to be 6.
Okay, great.
And they're all, I make sure that their heart's in it. If their heart's not in it, then they're not going to be with our operation.
How do you know? if their heart's in it? What do you ask
Well,
them?
you don't know right in the beginning. You know as you go
it's
through
always
time.
a question. People look good on paper, they're not always, or vice
Oh,
versa.
I know. You don't know until you get them in the seat whether they're going to be good. I did have to fire one of the chiropractors this year.
It happens, we have to,
And
we have to do the.
I had another interesting case, and only because it was shortly after I got into practice, and I did a report on kids diving into pools or something like that. So it's Memorial Day weekend, and it's the day after Memorial Day weekend. It's a Tuesday. I'm really busy because I was closed for a couple of days. This kid, 14 years old, rides his bike over to his office, and I knew the family very well, and I had consent to treat the child. Didn't necessarily have consent to take an X-ray, and his mother was in Europe, and he said, Dr. Walter, my neck hurts when I turn my head this way. I said, well, what happened? He goes, well, I was at Torbay Beach, and I dove into a wave, and I hit the sand. And I said, all right, Mark, just hang tight for a minute. I got a few patients, and I treated a few patients, said, look, we got to take an X-ray, and can you get in touch with your mother? I don't know. This is like before it was easy to call Europe, So we weren't able to get in touch with the mother, and I didn't have a good feeling of it. So but I'm not going to be a panicker. I took an X-ray, and this is when we used to have to develop them with tanks. I told him, Mark, go home. I'll call you tomorrow, and when I get a chance to look at the X-ray. So I finally get caught up with my patients. I put the X-ray on the view box, and he's got a burst fracture in the cervical spine.
Wow.
So I said, all right, I got to go find this kid. And I left my office. He brought his bike there. He lived around the corner. I knew where they lived. And I go knock on the door, and the great-grandmother, who only speaks Polish, answered the door. And I said, do you know where Mark is? She didn't know what I was talking about. But the little girl, who was like 10, spoke Polish and English, and said, he's out. And there comes Mark riding his bike. I said, Mark, we got to go to the hospital. And then I stayed with him until the next day. First, I took him to Amityville because we knew an orthopedic there was recommended. And then we ended up, I rode in the hospital, in the ambulance with him to Winthrop, where they eventually did surgery. First they did halo traction, that didn't work, and he eventually needed surgery. But, those are the things that can walk in, and you got to use judgment, and make sure that you take the X-rays when you know about these types of, that's a big red flag when anyone dives in and hits their head.
Oh yeah, that's a great pickup, and look at the outcome. Obviously, the kid got great care, and thank God, you took care of him.
Took care of him. Now he's
great.
In his 30s, but
I would imagine, since you're really so involved with your community and everything like that, you see a lot of your patients just at events and things like that all around the place all the time.
Again, it's a nice thing. I've become friends with a lot of our patients. I run with them and socialize with them, and I try to use a lot of them for our needs in the office. A lot of them, if they have a business, we try to use them because it kind of giving back to them.
Sure. Yeah.
And solidifies the bond between us. And, maybe you're supposed to, some people believe, you got to stay really professional and keep boundaries. I try to be as helpful as I can, and almost every patient, when they leave, I write down on their instructions. I said, look, if you ever have a question, here's my cell phone number. You can text me anytime. You know how often I get texts? Very few. People don't abuse it.
They know, yeah.
They know.
So your practice focuses mainly on spinal problems, though. But there are some chiropractors who do other. You hear about chiropractors treating like crazy stuff like acne and
GI
upset stomach
dysfunction and things like that.
Yeah.
I remember I went to visit a chiropractor's office. He had this million vials of different extracts all over his office. It was
What was he treating?
All kinds of things, migraines,
Herbs?
TMJ.
What do you think of that? It's a little odd, huh?
We treat a lot of migraines and headaches and TMJ, but I do it manually. I don't do it with.
I think that's
because the theory is because chiropractic thinks that it's all coming from the spinal nerves.
Well, a lot of the migraines can be. I
Yeah.
think there's a connection there. We see it a lot, and just doing manual therapy on pressure points around the head will give them relief. But headaches, especially the muscle contraction headaches, the success rate for us is really high. Migraine's not as high, but it's also high in some patients. So that's a common thing that we treat. And we do have some children and young adults that have constipation. And I don't go around telling people I'm going to solve their constipation problems and things like that. But the parents bring them in.
So what do you
And
do for
I
that?
know
How do you begin
I
with
just
that?
do the manipulation of the spine. And there are, The nervous system is connected to the motility of the digestive tract, and they get better. And the parents bring them back. And look, I'm not going to tell them.
I'm dying to have my daughter who has headaches.
Does she have constipation?
She's got other issues, but I think that chiropractors can really do a lot of things. Look, it's a you're
just coming from a different experience. That's.
Why not try some things like that rather than put him on a series of drugs? It's so nice to try to get away without the medications and things like that.
And structure has a lot to do with function. If the structure is disturbed, don't you think it can affect the function?
100%.
Yeah, I've seen a lot of chiropractors also work with
function follows form,
with acupuncturists and other types of modalities to get. Do you have acupuncturists in your office too?
No, but we have an acupuncturist in a couple of houses down, and
You have your people that you like to send.
I have my people. We do have the two things that we do have separate from the chiropractic is we have massage. We just started that this year because we expanded into another building that's adjacent to our office, and we're also doing assisted stretch. Which is very popular, and some of our
it's like a popular thing now. Is stretching.
Staff members.
You see these.
I think stretching is very important. I remember one time, I'll never forget. This elderly man came in. I said, "What is your secret for looking so good?" Stretching. That's the way to live.
So he stretches every day.
So, yeah.
What they do in Stretch Lab? Is that a chiropractic thing?
No, it wasn't necessarily a chiropractic thing, but
it's
the chiropractic
sort of thing probably
picked up on it, and we're pretty busy with it. The patients like it, and it brings new people into our practice.
I'll just say also about Dr. Priestley's offices. He has the nicest facility I've ever seen. It is a beautiful building. You go in there, you feel like you're in this old colonial, and it's just you feel like you're home there, and it's a nice place to go.
We got a fireplace this time of year. We fire up the fireplace.
Nice
a
landscaping.
Real fireplace.
I mean, he's very proud.
Oh, it's a house that's been converted to it.
It's over 100 years old. The house.
Oh wow, it's really nice.
Preserved
it's 5 minutes
a lot of the features
from my office in Bethpage, so it's really great to.
Is that Hempstead Turnpike?
It's right off of Hempstead Turnpike. It's like
it is Hempstead. It's Route 24, which is Hempstead Turnpike, and when it goes past Route 109, it becomes Conference Street.
Right,
it changes the name.
It's like one of those arteries that has different names depending where it is in your body.
Well, we're basically out of time, and we could talk forever about stuff that you're interested in, and we really just love having you here.
Yeah, we appreciate you coming here. We appreciate everything you've done for our patients. And
absolutely,
and we appreciate sharing your patients, and we'll do our best to make sure that they are well cared for, and hopefully we can help them. Not everyone we can help, but most we do.
I really appreciate it.
This was a lot of fun. Thank you for coming.
Yeah, thank you very much, Walter. You just got a great practice and stuff, and we'll definitely continue to work with you.
Well, just like you guys, I'm into it. You guys are into it.
Yeah.
That's what makes a difference. You got to be into it.
I love what I do.
That's why we did this podcast, because we were into it and we like to talk about the stuff we do and have the people that we're
there's a lot of myths about chiropractors, so I'm glad that you came here.
We dispelled a lot of myths today.
Well, look, it's hard to go against the status quo. It's the strongest economic force is probably the pharmaceutical industry, and it affects content on TV, and why they would bother putting an article about somebody who had a bad reaction to a chiropractic adjustment that's 1,000 miles away in a local newspaper here. It just doesn't make sense. Meanwhile, how many medical tragedies occur, unfortunately, every day in every town, and they're not putting those out there. It's kind of a sensational angle that they put out. And statistically, we wouldn't have the low malpractice rates if it was really dangerous.
Chiropractors wouldn't be around the way you guys are around if the things were so bad.
There's 50,000 of them in America, so you'd be hearing about a lot more.
People love their chiropractors.
My practice continues to grow, and whenever I see something on Facebook about, they ask, I'm looking for a chiropractor. Someone usually tags me, but there's like 20 people tagging a chiropractor because they're comfortable with them and they get results. I mean, we couldn't survive in this environment if we weren't getting results. It just wouldn't happen. And for me to employ like 20 people, it wouldn't happen unless we were getting results.
Yep, I agree.
There's no magic charisma or anything like that. I don't have that. I just have, hands that help and intuitive logic, and you explain it to patients in a very simple manner. And it makes sense. And I always tell them, well, the proof will be in the pudding. Let's get you on the table and see what happens. Give it 10 or 12 visits, and you should see some improvement. And if you don't, I got some other things you can do. And they usually get better.
Well, there you go. Well, anyway, this will then conclude our podcast with Dr. Priestley. Thank you very much for you guys for listening. And thanks again for coming on.
Pleasure. Yep.
Podcast.
Appreciate it.
Really do.